Colorectal cancer is the third most common cancer and the second leading cause of cancer-related mortality worldwide, and the liver is the most common site of metastasis. During the lifetime of a patient with colorectal cancer, 50 to 70% of patients will have metastatic disease, and about 30 and 40% of the time that is limited to the liver. So in patients with metastatic colorectal cancer that is limited to the liver, the real goal is to get them to Dr. Singh, is resection. So there are a variety of different techniques that Dr. Singh eloquently went through to get the tumor in the liver resected. We know that about only 10 to 20% of patients have resectable disease at initial evaluation, and with neoadjuvant therapy, about 40% could be downstage to resection, and Dr. Singh went through that with a lot of detail. But why are we trying to get these patients to resection? Simply because even as liver resections are done with a curative intent, they do have a very high recurrence rate, 60 to 80%. However, resections have a major impact on survival. So if you look at the long-term survival of patients with a resectable disease in the liver, the 5-year survival is in the 40 to 60%. In the subgroup where the disease is not initially resectable, but we get them to resection with neoadjuvant therapy, the 5-year survival is 33%. And if you can't get them to resection, chemotherapy alone results in long-term survival that's significantly worse. So the idea behind liver transplantation for this disease is basically trying to get this group here that has a poor outcome because you couldn't get the disease to be resectable to have a better outcome because you're resecting the disease. And so the concept of liver transplantation as treatment for cancer, conceptually simple. In essence, you have malignant disease that is limited to the liver, you do your scans, your staging, you don't see it elsewhere, and you can't remove it surgically for one reason or another, so you remove the liver, you replace it with a liver from a donor. So it's essentially the most radical form of liver resection, where you remove the entire organ. When this rather simplistic thinking about liver transplantation for malignant disease was applied in the 80s and 90s, this sort of paradigm was applied in a number of different malignant tumors of the liver, where essentially the concept is you do not see it outside the liver. It seems like it's all in the liver. We can't resect it. We just remove the liver and replace it. There's a number of studies of that early experiment. This is an example from published in 1990 for basically the experience in UCLA in the 1980s with this. And this is a variety of different malignancies. But you see that the 3-year survival on the average, and this is the average, goes below 40%. Now, from an oncologist perspective, you tell me advanced cancer, you do a surgery and you give them a survival of 40%, that's not too bad. But the issue is liver transplantation is not like any other treatment. The trouble with liver transplantation, and the challenge that we all have, is that it requires an allocation of a limited resource, which is donor organs. So when you're considering whether to use liver transplantation to treat something, what you have to consider is not only your conversation with the patient that's in front of you, based on everything else that we do in medicine, risks, benefits, alternatives, that's part of the conversation, but you also have to consider the use of that organ. So there is the benefit that that organ provides, since it's a limited resource. And the way I think about it when I'm seeing patients in clinic is every time I'm deciding to list this patient for liver transplant or give a liver transplant to this patient, there's another patient that died because they couldn't get the transplant. Roughly in the United States, about 25% of patients on the waiting list die without receiving a transplant. This is what changes the paradigm when you're considering transplant to treat something, is that you have to make sure that the use of the organ, it results in a good outcome. And the bar has been increasing. So this is the latest analysis of the national data for survival after liver transplantation. And you can see that a liver transplant provides on the average an 80% 5-year survival to someone. So this is a pretty high bar. So the previously described less than 40% 5-year survival from the experience in using transplantation in the 80s would clearly not be adequate. Obviously, you don't have to hit 80% every single time. It's an average. Some indications give you a better outcome, other indications give you a worse outcome, but this is the kind of benchmark that you have to consider when you're using transplant. So there are general principles for optimizing outcome when you're using transplantation to treat cancer. The most important one, like in many other contexts that you're treating cancer, is patient selection. You have to define the subgroup that actually benefits from the treatment. And this is not necessarily static, and this is the history of using transplant as treatment for cancer, is that we start with certain selection criteria, and the criteria get refined as we understand the disease better, and as we develop newer therapies to use in the neoadjuvant setting and in the adjuvant setting to improve the outcomes. So the two sort of general principles of using transplant to treat cancer that emerge from our experience in a variety of different diseases is that it appears in most cases, if you control the tumor before transplantation, that is a very important predictor of a good outcome. On the flip side, if the opposite happens, if the tumor is progressing, even though you do not see it outside of the liver, you go ahead and do a transplant, the outcome is generally not good. So this is like the emerging field in transplantation. Now, it got a name last year of Transplant Oncology because it started with HCC and it expanded to a variety of different cancers where there is good evidence that transplantation provides a substantial survival benefit and a benefit that justifies the utilization of an organ. And so the rest of the discussion, we're going to discuss how does this apply in colorectal cancer. So the first place that this was really experimented in is Norway. Norway has a very unique situation in that they have more livers than they have people needing transplants. They have more organs. So it's a good place to experiment with novel approaches to things in that sense. They don't have the same restrictions that we have in most of the rest of the world about this. So what the Norwegians had noticed is that this early experience that I had showed you earlier with poor outcomes was from the 80s. A lot changed since the 80s. Cancer therapy, colon cancer therapy had gotten a lot better, and also surgical techniques and the likelihood of having rejection after liver transplantation got a lot less, and better techniques, less rejection. And so a lot of these cases where the survival wasn't good was driven by a combination of oncological and transplant-related outcomes. And so they felt that this is a good time, in essence, to experiment with this again. And so what the Norwegians did is that they did a prospective single-arm trial called CK1, where they had 21 patients that had unresectable colorectal cancer. The primary had to be resected, and they had to have received at least 6 weeks of chemotherapy, after which there was no evidence of disease outside of the liver. And although they had a recurrence rate of about 90%, post-transplant overall survival at 5 years, 60%. This is, if you recall, the same sort of outcomes you expect from resections. You tend to have a high recurrence rate, but the survival is much improved over chemotherapy. Obviously, they expanded this study to a second prospective study, this time more fine-tuning the criteria, where they had to have longer observation without evidence of extrahepatic disease, more than 1 year since the primary was diagnosed. And they had to have at least 10% RECIST response in the tumor with neoadjuvant therapy. And in that group, the overall survival is even more impressive at 83%. Again, disease-free survival is only 35%. There's a substantial recurrence that happens, so it is not a curative transplant in the majority. However, the survival is much better than what you expect from continuing chemotherapy alone. And the Norwegian group published sort of historical controls on chemo alone, demonstrating that fact. Out of that original experience, we developed the score that was named after the city where this was done. The Oslo score was developed. Overall, with 61 patients, overall survival was 50% at 5 years. after transplantation. But the Norwegians developed these 4 criteria that predict a poor outcome after transplantation. Having a single lesion more than 5.5, having a CEA more than 80 at the time of transplant, and having diagnosis of colorectal cancer to transplant less than 2 years. Again, the longer you observe this and you don't see the disease outside of the liver, it means that the longer you have controlled it within the liver, the better the outcome. Again, a transplant oncology principle in general. And tumor progression immediately before transplant is associated with a poor outcome. So if you take that and assign 1 point to each of these, if you have an Oslo score of 0 to 2, your overall survival is 70% at 5 years. An important and interesting number, because you recall our benchmark is 80% at 5 years. We are essentially getting there with proper patient selection, good neoadjuvant therapy. And so all of this was done with single-arm studies. As mentioned earlier by Dr. Fakir, really what is substantially changing the paradigm is that the level of evidence got better. So the French did a 94-patient RCT where they compared 1-to-1 unresectable liver-only colorectal mets, 1-to-1 randomization, chemo alone versus transplant plus chemo. And in this instance, patients were given neoadjuvant chemo in every case, and in select cases, if the patients are tolerating, they also got adjuvant chemo. And of interest in the study, they had 47 patients in each arm, but in the transplant group, only 36 actually got transplanted because a small number of patients had progression before they could get to transplant that was either outside the liver on imaging, or when they took them to the OR to transplant and they found tumor outside of the liver, and so the procedure was aborted. In the chemo group, only 38 out of 47 remained on chemo alone. They had 7 patients who supposedly couldn't be downstaged initially to resection. As they continued on chemo, they resected 7 of them anyway. And they even had sort of a protocol violation where 2 patients on chemo got a transplant anyway. But the interesting thing is that if you look at this in the intention to treat, this is where obviously each group is analyzed, and the group they're assigned regardless of what happens afterwards. The survival benefit was highly significant, favoring the transplant group, 56.6%, but even more impressive in the per protocol group. So this is comparing patients in the liver transplant group who actually got transplanted, patients in the chemo group who actually stayed on chemo. The difference was tremendous. 5-year survival, 73% versus 9% in the patients who stayed on chemo. Again, this 70% 5-year survival, similar to the Norwegian experience that was described earlier in the group that met the low-risk criteria in the Oslo score. So in the US, our access to being able to use organs from the community to treat a patient with a liver transplant is regulated by the Organ Procurement and Transplantation Network, which is a government agency. It is contracting with a non-profit organization called United Network for Organ Sharing, UNOS. And the OPTN issues guidance on how to allocate organs for transplantation. And the OPTN actually, last year, based on all this impressive data, considered liver transplantation an appropriate treatment for select patients with colorectal metastasis, and they developed criteria that are similar to the trial criteria that I discussed earlier. But they assigned, the OPTN also assigns a priority, which is defined by the MELD exception score. So when you get on the list, your rank on the list depends on your MELD score. Most patients are on the list because their liver is failing, and that's what drives the MELD score, which is laboratory testing. And if you don't have a failing liver and you still need a transplant, you need an assigned score by the regulatory body. And the assigned score was 15. And if you're familiar with transplantation, that's a low score. The median MELD at the time of transplant in our area is 31. So when you assign a 15, you're assigning a very low likelihood of getting transplanted. And there are some justifications to that, and I'll touch upon that later. But as a result, access to transplantation for this indication is difficult, as it is, unless you have a living donor. In Norway, they don't have that problem because they have a lot of deceased donor. In France, in order to do the study, they got something out of the regulatory agency, which in the US people have tried and failed to get, which is allowing them access to organs just because they're doing a clinical trial. And we don't have that in the US. What we could do is use living donation, somebody donating to the patients. And I want to discuss the Toronto experience here in Canada that was particularly interesting in using living donor liver transplant for this indication. The way they did the study is basically they looked at all these liver-only colorectal cancer Mets patients that had unresectable disease, and they tried to downstage the tumor to a resectable stage, and if that's the case, they go to resection. And if they were not able to downstage to a resectable stage, then they would consider living donor transplantation. And in this cohort, this is overall survival at the time of evaluation. The transplant group did very well with overall survival. The resection group did similarly with a slight difference, and the patients who remained on chemo alone did substantially worse. And in disease-free survival, the transplantation group also did quite well, but important to note that there's only 7 patients that got a liver transplant in this study. And the impressive thing here is that they started with over 80 patients in order to get 7 patients to transplantation. So it just tells you how much effort this takes in terms of multidisciplinary discussions, treatment, follow-up, to be able to actually get to the patient that will benefit from transplantation, find them a living donor, which is an additional step, and finally get to transplant. In 2021, there's a group from the International Hepatopancreatobiliary Association that published consensus guidelines that derives criteria out of the studies that were published, mostly the Norwegian and the French studies. And these are the general principles around which patients with metastatic colorectal cancer to deliver are good candidates. Tumor has to be unresectable. We still would have patients go to resection if they're resectable. At this stage, there's no evidence that transplant is better than resection in any meaningful way. On the average, the outcome of resection in terms of 5-year survival is similar to the best case scenario in transplant. So in essence, there's no reason to do a transplant if the disease is resectable at this stage. You have to have the primary tumor resected. You have to have no extrahepatic disease other than nodal disease at the time of resection. And you have to have some long-term observation on therapy without development of additional sites or extrahepatic sites of disease like lung mets or other. And response to therapy, no progression is a requirement. This is in its infancy. I think the molecular aspects of colon cancer care, which is getting to be very important, circulating tumor material, monitoring for recurrence, etc., has not been integrated in those protocols. So this is really an area for future development for sure. But what we know is that BRAF mutant tumors are considered contraindication because of their aggressiveness. And if you have MSI unstable tumors that tend to respond very well to immune checkpoint inhibitors, it's a relative contraindication. You want to avoid transplant in that instance because the ICIs will increase the risk of graft rejection, which is a very well documented problem. And obviously this is patient in good health, no end organ disease, candidate for liver transplant, and preferably having a living donor. These are generally the patients that will do well. So to answer my original question, should liver transplantation be a standard treatment option for metastatic colorectal cancer? The answer is yes, based on all the discussion. There are caveats, and I'll mention a few. Out of the Toronto experience and our experience, we have it's kind of a similar experience with this, is that pretty complicated. You have to have a good, solid multidisciplinary team. Oncology is used to having multidisciplinary team, but now you're integrating transplant hepatologists and transplant surgeons and organ access decisions which increases the complexity. Other problem, we have about 150,000 colorectal cancer cases a year in the US. 30,000 will have liver-only colorectal mets. This is back of the envelope calculations. Let's say 10% are unresectable and good candidates for transplant. You're asking for 3,000 more livers. This is a third of all the available livers in the country. So how are we gonna actually do this is gonna be a challenge, knowing also, okay, living donor is a way to bypass the availability of donors from the community, but the entire number of living donors done in the US in the past year is 600. So it does not meet the need. So this is probably the rationale behind assigning a relatively low exception points for these patients. It's just because if we probably don't have enough organs if we're gonna make this mainstream and apply it to everybody. So this is a problem that needs a solution at this stage. And finally, there's attention that is needed to avoid exacerbating existing barriers to transplantation. We know as you put more strain in the system, you're asking for more organs to be aligned. There is a population of patients that historically, economically, as well as economically challenged minorities that will have difficulty accessing it because of difficulty with insurance, language, cultural barrier. Transplant requires a lot of supportive structures on the family side. This is a patient needs an extensive number of testing, very, very close follow-up, laboratory tests very often. And anybody who doesn't have a family member with a lot of dispensable time will be challenged, and that causes disparity in access to transplantation, which is a major problem. It is also even harder if you also need to have a living donor on top of that. But I think the future is bright for this. We still have to know how to do it well, how to use all the developments in molecular biology and the molecular understanding of tumors in applying this to extend the access to surgical disease for some patients with metastatic colon cancer. And this was my last slide. If I can make it. There we go.